Okay, so I already introduced myself. And I'd like to begin my conflicts of interests. So I'm editor of the Journal of Neurology and Frontiers of Neuro-otology. As you see here, I have been lecturing for various companies. So in terms of the products which are on the market, I'm quite well balanced. I'm also the inventor of the so-called gafas de Miguelito. And my youngest daughter, Amelie Christine, programmed the so-called Positional Vertigo app, which you can download for free from the App Store. It exactly shows patients in English and German on how to perform the therapeutic maneuvers for BPPV. I have quite extensively published, and you will see some of these publications during my presentation. Last year, we published this book. It's about 405 pages, and it covers the whole field. And that's going to be also the topic tonight. So we will cover the most frequent peripheral, central, and functional vestibular disorders. And since we are here in the audience, a small group, it can be interactive. I was informed that we also have other colleagues who join us virtually. So actually, we have a hybrid meeting, which is really up to date and saves a lot of traveling. What are the aims? E to the power of 4. E stands for entertaining you, enlightening you, education, and excitement. And maybe you have more words which begin with the letter E. The presentation consists of a short introduction. And in the introduction, I will focus on how to take patient history, how to examine the vestibular system and the oculomotor system. And this is the basics to make a diagnosis. Actually, you don't need very few machines. That's a nice thing with vertigo and dizziness. The complicated thing with vertigo and dizziness, vertigo y mareo, is that it's the leading symptom of many different diseases with a broad spectrum of etiologies. So you can have a tumor, you can have a stroke, you can have multiple sclerosis, you can have a viral inflammation, you have migraine, you have a neurovascular cross compression, and that makes the topic a little bit demanding. Nevertheless, based on the patient history and the examination of the patient, you can. You will notice during the first 5 minutes that the number 4 counts. Sounds trivial, but it's straightforward because we have just 4 key questions when you take the patient history. We have 4 bedside tests for the vestibular system. We have just 4 relevant bedside tests for the oculomotor system. If a patient comes with acute vertigo, there will be 4 central signs to differentiate whether it's central or peripheral. We have 4 laboratory tests and 1 is only relevant. We have 4 categories of diseases and 4 therapeutic principles. So 7 multiplied by 4 is the key to the diagnosis. If we go into the details a little bit, and I will elaborate that in greater detail during my presentation, 4 questions, the time course of the symptoms, the type is not that relevant, triggers and accompanying symptoms. This is analogous to headache. 4 tests, you look for a nystagmus, you do the head impulse test, you do the diagnostic positioning maneuvers in every patient, and the Romberg test. When a patient comes with acute vertigo, you look for central signs. And one central sign is one eye above the other, deviation verticale. If you see that with a cover test, it will be central. You examine smooth pursuit, gaze holding function, and saccades. That's all. And here are the 4 central signs. I already mentioned deviation vertical. Nystagmus not suppressed is not peripheral. You look for a gaze-evoked nystagmus, and if a patient has acute vertigo and a nystagmus, and the head impulse test is normal, this will not be peripheral. Here are a little bit more detail, the 4 tests for the vestibular system. So you can use Gaffas de Miguelito to look for a nystagmus, head impulse test. This here is a new diagnostic positioning test. It's called the Summer Plus test. We talk about that later, and the Romberg test. And your tuning fork is very helpful. You can test hearing with the Romberg and the Weber, and also you test vibration sense. So almost no machines. Oculomotor system, you see here the cover test. You see here smooth pursuit, gaze holding function, and saccades. This is relevant. Everything else is clinically not relevant. It's academically interesting, but clinically not relevant. And here, if you like to earn a lot of money from your patients with a private health insurance, you do all these tests. We do that in our hospital. Okay. But the really relevant test is in the left upper corner, and this is the video head impulse test. So for rational diagnostic workup, the head impulse test is sufficient in most patients. That means if you like to invest in the head impulse test. This allows you a quantitative evaluation of the function of the vestibular ocular reflex. Now to the 4 categories. And 3 of them are relevant only. Number 4 is not relevant. You can have peripheral vestibular disorders, labyrinth and/or vestibular nerve. Central means brainstem and cerebellum, supratentorial structures are clinically not relevant. So if you do imaging, look at brainstem and cerebellum. Then we have non-vestibular, and by far the most relevant is mariofunctional. Call it mariofunctional, and not psychiatric, psychosomatic, psychogenic. That will damage the doctor-patient relationship immediately. You need half an hour to rebuild it. Mariofunctional, we'll talk about that at the end. And the others, if vertigo y mareo are the leading symptoms, are not really relevant. They're most often overestimated. And there's nothing like cervical dizziness. It's not existing. Good. Here you see for more than 45,000 patients from our center, the relative frequency of the various diseases, including the 4 categories. Mariofunctional. In black, you see the peripheral vestibular disorders, and that's good for the ENT because they cover the vast majority of patients. Then we have central, micrania vestibular, and vertigo y mareo central, and then unknown causes. That makes about 10%. Even in a specialized center, in 10%, the diagnosis remains unclear. This requires follow-up examination of patients. So we have to be realistic. What we have done over the last 14 years, we have reclassified all vestibular disorders. Actually, we have published in the classification committee 16 papers. And the nice thing is that you can download all these papers. By the way, if you like, you can take a video or a photograph. You can download all these papers for free from the website of the Journal of Vestibular Research. I will show the criteria related to the diseases tonight. The other one are also clinically oriented. This is not bloody academic medicine. It's clinically oriented medicine to make the diagnosis. And when you have a look at the diagnostic criteria, you will notice patient history, bedside examination, very few machines. So you need an audiogram for Meniere, you need the video hit for vestibulopathia bilateral, but the rest is bedside and listening. That's it. It makes it really easy. Not trivial, but easy. Okay, what is the content of the major and second part of the presentation? First, we talk about the 3 most frequent peripheral vestibular disorders. Then we talk about central vestibular disorders, namely acute vestibular syndrome. Patient comes with acute vertigo first time. Is this a stroke or is it something trivial? And you have to learn to discriminate. And finally, we will have functional dizziness. And each of the diseases will be introduced by a video quiz. So you listen to a patient and make the diagnosis. Then we talk about the diagnostic criteria, pathophysiology and etiology, differential diagnosis and current treatment. And the attitude is, change it. Yes, I can. It's not magic. It's good clinical medicine. Don't be afraid of that. Love your dizzy patients and they will love you. Because you often make the diagnosis for the first time after they have been seen by 10 different doctors, typical doctor hopping. Diagnosis is cheap and treatment is also cheap and based on clinical studies. I will also present you a paper at the end, which we published February 1st in the New England Journal of Medicine, a new therapeutic principle. I have been working on this molecule for 12 years. And it ended up in a positive phase 3 trial in a disease which is quite frequent in your country too. And we have new treatment options. New England Journal of Medicine, the best of the best. Okay, so now let's start with peripheral vestibular disorders. And this slide is very important for your understanding and for your taking patient history. Based on the pathophysiology, the clinical presentations, and the signs of symptoms. There are 3 categories on how patients can present, and the same is true for central. So patient can have a vestibulopathia bilateral, loss of function of both organs of balance. The leading symptom is mareo, not vertigo, and postural instability. Patients typically have no symptoms while sitting or lying down like you, because we don't need the vestibular system under these conditions. But as soon as they get up, they feel dizzy, and it's worse in darkness and on uneven ground, analogous to the Romberg test. So vestibulopathia bilateral. Then we had vestibulopathia unilateral aguda. There's an acute loss of function. The other labyrinth is still active. And then you get spinning vertigo rotatorio, with a nystagmus and a pathological head impulse test. This is centrally compensated. Symptoms last for several days. And most frequently, you have episodic vertigo. And this is in contrast to what is commonly believed, most often excitation. Excitation. In BPPV, excitation. Enfermedad de Meniere, initially excitation. Paroxysmia vestibular, neurovascular cross compression, excitation. Very rarely there's an inhibition, because excitation is up to 500 hertz possible and inhibition only from 100 to 0. And therefore, excitation is more relevant for the pathological excitation for the vestibular system. And this is episodic vertigo. This slide here shows the underlying etiology. And you can see that we do know exactly what is wrong. VPPV, crystals in a canal, most often posterior. Enfermedad de Meniere, endolymphatic eye drops, rupture of the membrane. Paroxysmia vestibular, analogous to trigeminal neuralgia, neurovascular cross compression. Vestibulopathia bilateral, most often degenerative, but also genetic disorders, as we recently showed. Vestibulopathia unilateral agudo, herpes simplex, and something rare for the surgeons, syndrome of the third mobile windows. Superior canal dehiscence syndrome, a bony defect, pressure-induced symptoms. So we know everything about it. We know the physiology, pathophysiology, anatomy, and etiology.
Dr. Mittens, why do you come to our hospital, please?
I have a sort of dizziness and imbalance.
For how many days or weeks?
3 or 4 weeks.
Mm-hmm. Did you have that before?
I had that months ago and even years ago.
Do you also have spinning vertigo now?
No spinning.
Do you have positional vertigo?
No.
Thank you very much.
So that's a typical atypical patient history. Does anybody have an idea about the diagnosis? So this elderly lady has episodes with symptoms. A, B, C, D, E? Yes, periods with symptoms in the past, then it went away, and then it came again. What? I don't know yet. What do you have to do in every patient, every time? Diagnostic positioning maneuvers. The prevalence of BPPV is 10%. So one important take-home message for all of you tonight is diagnostic positioning maneuvers in every patient with vertigo y mareo every time. Every time means you can have a patient with enfermedad de Meniere plus BPPV. It's very frequent. So the final diagnosis was posterior canal BPPV. Yeah? And what we have done together with physicists from Switzerland is a simulation of what is going on in the labyrinth. You see here, these are the crystals. If you turn the labyrinth by 90 degrees, the crystals move only 70 degrees. After I noticed that, I modified the simmer to the simmer plus. And we have done 2 clinical trials and could show that this is the very best maneuver in the world. I'll demonstrate that later with a volunteer. Because what we have done for the diagnosis and treatment is an overextension of the head by 60 degrees. Simmer plus. I call it simmer plus or plus because we added just 60 degrees. I didn't call it Strupps or something, which would not be justified. So, and the clue is, you see it on the right side, if you move the labyrinth by another 60 degrees, the crystals move simply during the first movement already 60 degrees into the direction they should move. This increases the sensitivity of the diagnostic test very much, but even more important for the treatment, as you will see in a few moments. And here's a simulation which we did together with colleagues from India. You see here on the right side what is happening. You turn the patient's head 45 degrees to the left, then the patient moves down 60 degrees below Earth horizontal. And the crystals now move beyond the vertex of the canal. That's the clue. Because if you then move the patient by 240 degrees into the opposite direction, and the head must always be turned 45 degrees, the crystals are already beyond the vertex of the canal. And that's the clue. So theoretically, this should increase the effectivity of the maneuver. It's very simple. I'm a simple-minded neurologist. You don't need to translate that. And then the crystals are already there. And then we did 2 prospective studies with a similar design together with colleagues from Belgium and Italy. It was very simple. 9 maneuvers per day. This is what the patient should do. 9 per day for 3 days, by the way. Then you cure 99%. And here are the results. So in green, the time it took with a regular simmer maneuver, 3.6 days, and with the simmer plus, only 1.8 days. That's dramatic. This is not very moving for you because you most often use the Apley maneuver, and it was also not moving for gringos. So we compared the Apley with the simmer plus. And here again, there was a significant reduction from 1.9 to 3.3 days. And here you see how the maneuver is performed. So patient turns the head, she has right posterior canal BPPV, 45 degrees to the left, and then she moves the whole body here down below earth horizontal. This position is kept for 60 seconds, and then she moves the whole body in the opposite direction. Another 60 seconds, and then she sits up. That's the most effective maneuver for posterior canal BPPV. Published in JAMA Neurology, which is a fine journal. Okay, very important that the head is really turned by 45 degrees, otherwise the crystals will not move because gravitational forces are too low and the crystals are attached to the endolymphatic membrane. So that's very important. And that also explains why the SMHAP Plus is superior to the Apley, because here Apley, you have one position where the canal is quite flat, and then the crystals don't move. The opposite is, if you then turn back, the crystals move in the opposite direction. My youngest daughter, Amelie Christine, programmed this positional vertigo app, which you can download from the App Store for free, because there's a bug at the moment. Normally you pay $5 US. Currently you get it for free. Positional vertigo app. You can listen to Michael Halmagi's voice in the English version for the therapeutic maneuvers SMHAP and SMHAP Plus. That's all theory. How does it look like in clinical practice in patients? How do they do the maneuvers? On the left side, you see this couple was very much engaged. Patient had right posterior canal BPPV. They got detailed instruction, but you see they didn't do it in a proper way. So use your smartphone in a smart way to check whether patients do it correctly or not. Most often, it's not correctly done. This year we published in another JAMA article. That's the ideal position for the SMHAP Plus on the patient's bed. Touch ground with your hand. And then after 60 seconds, the patient moves into the opposite direction. So the treatment is highly effective. Recurrency rate is 50%. Be aware of that, so patients can come back and complain. Another thing which we have designed is a so-called A-stabilizer app. We are all aware of patients who come to you, they have episodic vertigo, you examine the patient and you don't see anything. Then what we give these patients is this eye stabilizer app. And you see, this is what you see on your normal camera, and this is what the eye stabilizer app makes out of it. So the eyes are always in focus, and that's what counts. So during the therapeutic maneuvers, you see the eyes very sharply, and this allows you to make a precise diagnosis. You see here, this is what the camera shows, and this is what the apps makes out of it. Very helpful. So, conclusions from tomorrow morning on, use the SMHAP Plus maneuver. It's very effective. The head should always be turned 45 degrees, and you will be amazed to see how well it works. 3 times in the morning, 3 times at noon, 3 times at 9 for 3 days. 27 maneuvers will do the job. Okay. Now we move to horizontal canal BPPV, and there we have a new maneuver. It's a so-called modified roll maneuver. If you have right horizontal canal BPPV, you first turn the patient to the right and then in 90-degree steps toward the healthy side. Then you remove all the crystals, and then the patient should sleep on the healthy side. Therefore, I call it roll and rest. This is the treatment for canalolithiasis, and the treatment for cupulolithiasis is very easy head shaking. Then you remove the crystals from the cupula. Okay, canalolithiasis, roll and rest, cupulolithiasis, head shaking. Okay, here the essence. By the way, you can take a photograph if you like. So BPPV is very frequent, lifetime prevalence 10%. It typically begins in the early morning, most often the posterior canal. 95% idiopathic. Major risk factor is aging and head trauma. SMHAP plus for posterior canal, modified roll and rest maneuver for horizontal, and the modified Jacobino maneuver for anterior canal. Okay, some caveats. On the one hand, it's too frequently diagnosed. On the other hand, it's overlooked because not all patients are examined by the diagnostic maneuvers. Convince yourself. And every patient needs diagnostic maneuvers during every visit and follow-up examination after 2 to 4 weeks. So it's a very standardized operational procedure. It's easy to diagnose and very cheap and successful to treat. Good. Now listen to the next patient. The history will be in Spanish. I hope we have a good sound.
¿Qué molestias le trae aquí?
Hace 4 semanas tuve una infección vírica de un solo día y al día siguiente tenía mareos, como si estuviera en un carrusel. Me era imposible ponerme de pie.
¿Cuántos días duraron los mareos?
El mareo fue muy fuerte durante 2 días. Durante ese tiempo no podía andar, pero mejoró lentamente en las semanas siguientes.
¿Qué síntomas tiene usted ahora?
Todavía noto que cuando giro la cabeza rápidamente en una dirección es como si el cuerpo quisiera seguirla. Me siento un poco mareado.
¿Alguna diferencia entre el lado izquierdo y el derecho?
Tengo la sensación de que es más fuerte el derecho.
Mirando hacia atrás, ¿tuvo usted algún otro síntoma como pérdida auditiva, problemas para hablar, problemas de coordinación o parálisis de algún tipo?
No, nada.
So do you have an idea about the diagnosis? So, okay, let us see another patient with the same diagnosis and have a look at the findings. She's looking now straight ahead, so there's no deviation vertical. You didn't see a nystagmus when you put on gafas de Miguelito. You see a nystagmus which beats to the right. The fast phase is always beating towards the more active labyrinth, double A, fast phase active labyrinth. When she now looks to the right, the intensity increases. When she looks to the left, there must not be a direction changing nystagmus. No left beating in this patient. And the final test which you do is the head impulse test, and then you have the diagnosis. So it's a question of 5 minutes. You do the head impulse test too slowly, you won't see anything. You have to do it very abruptly. This video is extremely slow. Therefore, you don't see the refixation saccade. This is because of the projection mode we have here. So she had a pathological head impulse test to the left. Okay, so vestibulopathia aguda unilateral, which we published in 2022, the classification paper. Sustained spinning or non-spinning vertigo with an acute onset. A peripheral vestibular nystagmus suppressed by visual fixation. Clear VOR deficit, and no pronounced skew deviation, and no gaze evoked nystagmus. We've done a lot of molecular biology studies and demonstrated that in healthy individuals, 60% of the examined vestibular ganglia contained herpes simplex virus. And we also did a genome-wide association study and found changes in the so-called host factor for the herpes simplex replication. All that makes it very likely that herpes simplex is the underlying etiology. And here a summary of the treatment. If you like, you can take a photograph. So steroids in the acute phase. I published the paper in 2004 in the New England Journal of Medicine. That was the first controlled study. And it's now also supported by the guidelines of the American Emergency Medicine Association, published last year. begin with 100 milligram for 3 days, 80 milligram for 3 days, and so on. For symptomatic treatment, diamine hydronate, and we talk about beta-histine in a few moments, and also about vestibular exercises. Oh, you hardly see that, what is going on here. This is a control animal. I don't know why it's so slow now. We have a problem evidently with the zoom and the transfer rate. So well, this video on the left and the right should show us that a treated animal with beta-histine is much more agile than a control animal. They all got a left-sided chemical labyrinthectomy, and this animal is much more vivid than this one. And this is something we also quantified. And what you see here is the total distance the animals walk and the total time the animal is moving. If you give beta-histine, these are the high columns, it has definitely an impact. It works. Question is only the dosage. Our experience is the higher the dosage, the higher the efficacy. And we also performed so-called micro FDG PET, and thereby we could demonstrate that beta-histine is activating the ipsilateral vestibular nucleus, which explains the reduction of the symptoms, and it also activates the cerebellum, which explains its effects on central compensation. So it's definitely effective. The problem is the dosage. So for us, the minimum dosage is 96 milligram 3 times per day for 2 weeks in vestibulopathia aguda unilateral. We can also explain why this is the case, and the low dosage is not effective. So the Wi-Fi is a little bit unstable. What is the mechanism of action? This is a little bit difficult to understand. Actually, I didn't understand it the first time either, but I tried to explain it. Okay, beta-histine is inhibiting the H3 receptor. The H3 receptor is a so-called presynaptic autoheteroreceptor. Sounds complicated, it's easy. If you block this receptor, more histamine and other transmitters will be released, and that's the mechanism of action. So inhibition of H3 leads to an increase of the release of transmitters, and this facilitates central compensation. And that's the mechanism of action. So here again, for those who haven't taken a photograph, methylprednisolone, diamine hydronate for 1 to 3 days, beta-histine 48, beta-96 3 times per day. If you're very clever, you can combine it with siligeline 5 milligram, which is a MAO-B inhibitor and gives you 100 times higher bioavailability, as we showed last year. It's cheap and very effective, and vestibular exercises. Okay, now we come to the third and last peripheral vestibular disorder. Listen to this patient, please.
Acude a nosotros debido a que sufre mareos recurrentes. La última vez fue anoche. ¿Podría describirlos?
Sí, ayer tuve un día muy tranquilo. Por la noche me senté a leer el periódico y de repente me mareé. Todo empezó a dar vueltas y ahí es donde normalmente tengo que acostarme. Sentía un ruido enorme en los oídos, una presión cada vez más fuerte. Cuando me acuesto en la cama, necesito al menos 3 horas para encontrarme mejor. Aunque, en el peor de los casos, puedo tardar hasta 10-12 horas.
¿Tiene problemas de audición durante estos episodios?
Sí, oigo muy mal. Esa es otra.
¿En qué oído tiene problemas?
Especialmente el derecho.
¿Y cuántos ataques ha sufrido en los últimos 3 meses?
Unos 10 ataques.
Muchas gracias.
De nada.
Enfermedad de Meniere is very frequent. Be careful, there are patients who have vestibular migraine and Meniere's disease. So if a patient sounds like vestibular migraine, ask for hearing problems. If a patient sounds like enfermedad de Meniere, ask for headache and hypersensitivity to light and sound. So this is probable Meniere's disease. To make a precise diagnosis, you need an audiogram, and it's required that the patient has an impairment of at least 30 decibel below 2000 hertz. But they can also have a pantonal hearing impairment. Okay, nicely, last year, 6 Cochrane reviews were published, and that's bad news for many ENTs. Learning and de-learning. So there's no evidence that gentamicin or corticosteroids have an effect. Very weak studies, and there's always a strong placebo effect. Positive pressure, no evidence. Lifestyle and dietary interventions, no effect. That means salt-free diet, alcohol, coffee, whatsoever free diet is not effective. Surgical interventions, neither. Beta-histine, we'll talk now. You know this slide. So beta-histine, as I told you, acts on the H3 receptor, and this increases the release of histamine. And histamine receptors you find in a very high density in the endolymphatic membrane. If you activate histamine receptors, membrane permeability increases. You know that from the edema. The same is happening in the inner ear. That means due to the release of histamine and the activation of H1 receptors, the membrane permeability of the endolymphatic membrane increases, and this leads to a reduction of endolymphatic pressure. It often takes 3 months until you have the full effect of a treatment with beta-histine. And therefore, what we recommend, apply the diagnostic criteria. Drug of choice is beta-histine. My recommended dosage is 96 TID. Yeah, but this is expensive. So we can go to 24 TID plus 5 milligrams siligylene. You will be amazed to see how well it works. I have about 500 Meniere's patients I'm taking care of. 19 out of 20 become free of episodes. And it's a long-term preventive treatment similar to migraine. Okay, now we went through the 3 most frequent peripheral, and now we switch the topic to central. If you have a look at the slides, this should be familiar because central diseases present in the same way as peripheral. You can have an acute vestibular syndrome in brainstem or cerebellar infarction. You can have episodic vertigo, most frequently in micrania vestibular, or you can have persisting symptoms, cerebellar, extrapyramidal, or brainstem dizziness. So it's basically the same.
Ms. Baum,
We need
you
a
came
sound.
to us 2 days ago. Tell me how the whole thing went. You have bent down. Did you then get up?
I got up. I was sitting on my bedside, bent to put on a sock, and then I just got dizzy and sick. It was so severe that I woke my husband because I didn't know how to help myself anymore.
And then you had a headache afterwards. How long did that last?
For half an hour, maybe?
Acute vertigo after she got up, and then she had a headache. And that was the very first episode. What should you not diagnose? She had a basilar thrombosis, a PFO, a patent foramen ovale, paradoxical embolism. So be careful. Patient, acute vertigo for the first time plus headache, most likely a stroke. First time, vertigo and headache. Vertebrobasilar ischemia often causes headache. So she had this thrombosis, she got IV thrombolysis and mechanical recanalization and survived. So caveat, vertigo plus headache for the first time, think this can be stroke. Next.
Mr. Knauenhauser, what brings you here today? On Monday afternoon, I experienced severe dizziness. Was it a spinning sensation or a swaying sensation? It was mostly a swaying sensation. That did you experience a tendency to fall to one side? Not as I noticed. At least, I was just barely able to make it the short distance from the living room table to the sofa while supporting myself both on the left and the right.
So, acute imbalance. It's not vertigo, it's mareo, imbalancia. This is most often a stroke, a cerebellar stroke. Explanation is simple. If you have a peripheral problem, it's most often manifesting with vertigo rotatorio, okay, from the semicircular canals. But acute imbalance is most often a stroke. So this patient here had a cerebellar stroke. That's the second scenario. And the third scenario is combination of vertigo and hearing problems.
Mr. Fisher, 2 days ago you experienced sudden dizziness. Please describe how all this started and what other symptoms you had.
Okay, 2 days ago I first had a problem with my hearing, a hollow, loud sound on the right side and dizziness at the same time. First of all, I was disoriented. Neither arm worked properly anymore. I could no longer coordinate the movement of my arms on the right and to the left.
So acute hearing loss and acute mareo for the first time. ICA infarction. Yeah? Okay, so testing of hearing is good for Meniere's disease, but also for an ICA infarction. So that's very important for you. Please take a photograph of this slide because it will help you with the next patient with vertigo y mareo agudo. So what makes it more likely that this is central? First event and longer duration. Mareo imbalancia. Symptoms occur spontaneously. You have to ask for central accompanying symptoms. Patients do not tell you. A high ABCD square score, A stands for H, blood pressure, central symptoms, duration longer than 60 minutes, and diabetes, and 4 central signs. So here are the 4 central signs. And they are very effective. They're better than your best neuroradiologist. So one eye above the other, deviation verticale. Nystagmus not reduced by fixation is not peripheral. Patient has a spontaneous nystagmus, let's say to the right. Then he looks to the left and you see it's now beating to the left, direction changing nystagmus, and a normal head impulse test in acute vertigo and nystagmus, not peripheral. We recommend CT angiography in the acute phase. That's sufficient to exclude basilar or vertebrals thrombosis. MRI is often normal within the first 50 hours and 50%, so useless. You can do that later. If you're not sure and there's no evidence for bleeding, etc., treat like a stroke with aspirin and atorvastatin. You will not go to court. Okay.
Ms. Coop, what symptoms are you coming to us for?
For problems with dizziness.
How many years has this been going on?
About 3 years.
Is it a constant feeling of dizziness or do you get attacks?
Constant dizziness.
Is that more of a spinning or a swaying feeling?
Swaying and difficulty walking.
How is it when you look to the right and left?
Then I have the feeling that my eyes can't find a point to orient themselves around.
What about when you walk in the dark?
Quite bad.
Thank you very much.
So now look what is happening when she's looking to the left and to the right. What do you see? What are the eyes doing? Nystagmus. A downwardly beating nystagmus. So this is a typical downbeat nystagmus syndrome. Every vertically downwardly beating component qualifies for downbeat nystagmus. It's the most frequent acquired persisting and it's part of mareo cerebellar. Okay, so here are the features. The intensity increases during lateral and downward gaze, and that's a cue. Examine the patient when he or she is looking to the right and to the left. Then you often see it, otherwise you miss it. So pathophysiology, we elaborated in 2 studies. and it's a hyperfunction of the flocculus. The flocculus normally inhibits the superior vestibular nuclear neurons. If they are disinhibited, the eyes drift upward and be downward. Okay, that's the same what you do when you bend the head downward, then you activate the same neurons. Yeah, downbeat nystagmus, we did 2 very relevant genetic studies. They're really, really important. So in this so-called genome-wide association study, we found a locus here in the fibroblast growth factor 14. This is relevant for the excitability of Purkinje cells. If this is impaired, there's a disinhibition. But it goes even further, as I show you later, because if you have a mutation here, you respond to fampredine. And this is precision medicine. These are the drugs which, with all modesty, I have introduced over the last years. We'll talk about this molecule later, but now we talk about this potassium channel blocker, which is the treatment of choice for downbeat nystagmus and episodic ataxia type 2. It's a potassium channel blocker which increases the excitability of Purkinje cells. Here you see the very first patient we treated. On the left side before, on the right side during treatment. You see the clear clinical benefit. And it has turned out to be the drug. Oh, now we have a big issue here. A magnification, which I didn't intend to do. Okay, we go back. Okay, so these were the first papers which I published in downbeat nystagmus and episodic ataxia. And this is the mechanism of action. Potassium channel blockers increase the excitability and resting discharge rate of Purkinje cells. They become more active, and the increase of GABA will lead to an inhibition of vestibular nuclear neurons. That's the mechanism of action. We did several studies with 4-aminopyridine, and it turns out to be the drug of choice. And now I come back to what I said before. If you have a mutation in the fibroblast growth factor 14, 80% of the patient respond to a treatment with Famprera, if not only 40%. That's very helpful. Now listen to the patient and how was the impact of this treatment with Fampredine. Oh, that's a German version. I'm very sorry for that. We have an English version. I mixed that up. At least she could leave the house without her husband. She's much better. This is what she told us. And the intensity of the downbeat nystagmus is also reduced. We have an analogous disease, episodic ataxia type 2. And here the treatment of choice is also, as we showed in this clinical study published in Neurology, Fampredine. It reduces dramatically the number of the episodes, and it's much better tolerated than acetazolamide, which had been the drug of choice before. 24 out of 27 patients were on 4-aminopyridine and only 3 on acetazolamide. And this is the spectrum of the indications. You have Fampredine here in Mexico too. It's quite expensive. What I recommend is that you have a good pharmacist who puts 4-aminopyridine in a capsule, 5 milligram capsules. It costs almost nothing. And the dosage is 3 to 4 times a day. That's a good alternative. That was, by the way we started the treatment. Fampredine was approved much later. Now, look at this patient here on the left side. She should perform vertical saccades. Is she able to do that? No. She performs what is called walking around the house. So she's not able to perform vertical saccades. If you see that in a young patient, what is the diagnosis? It's a lysosomal disease, Niemann-Pick type C. So, We did a study in 72 patients and 71 had this vertical saccade palsy. So the examination in unclear cases of movement disorders and ataxia of vertical saccades is extremely helpful, and it has therapeutic consequences. So in 2013, I introduced this molecule for ataxias, and we did a case series here in Niemann-Pick type C. And here you see a patient on the left side before treatment, and on the right side during treatment. You don't see the difference that much because the video is quite slow, but you see the coordination is much better. Yeah, and that's a very consistent finding in patients. You see here another boy. He has something similar. It's called Santoff and Tay-Sachs disease. It's also a lysosomal disease, GM2. This is Dario before the treatment. So he's hardly able to stand without help. And normally this goes fluently. I don't know why it's so slow. It's because of the Zoom. So at least he's able to walk unaided over a football field. So that's a dramatic improvement, which is quite consistent. And we did two studies, phase 2 studies, which were positive, and this paper was published in the New England Journal of Medicine February 1st. 12 weeks of treatment or 12 weeks of placebo and vice versa. And here there was an improvement on this scale by 2 points, and 2 points means quite a lot. Here you see a patient on the left side before and on the right side during treatment. So again, he could walk unaided. And the drug has a clear neuroprotective effect. It will be relevant in many neurodegenerative diseases. I promise you, we have very good data. And 2 points means, for instance, many words difficult to understand versus impaired speech, but easy to understand. So it's a really game changer. We know the mechanism of action. It improves the glucose metabolism, so more ATP is produced. It brings every cell in the body in a better shape. It also has a nice anti-aging effect. We did basic studies in animal models, and now we do a little bit of basic research. You see here an untreated mouse and a treated mouse, and the treated mouse is much faster. And we elucidated the mechanism of action carefully. Here is a mouse with a Tay-Sachs disease on the left side, the untreated, and on the right side, the treated mouse. So it works not in patients only, but also in animals. And then you can elucidate the mechanism of action. And it extended the lifespan of the animals by more than 10%. And here we treated patients, 12 patients, and after 1 year of treatment, they were better than before. Can you imagine that in a neurodegenerative disease? Yes, you can. And therefore, I'm so excited about this. So we talked now about central vestibular dysfunction, and that's going to be the last patient and the last disease. Listen to this young engineer.
Señor Bielsak, ¿qué molestias le han traído aquí?
Tengo mareos, en lo que todo se balancea y aturdimiento desde hace 1 año aproximadamente.
¿Cómo es por las mañanas cuando se levanta?
Nada más levantarme no tengo mareos, solo cuando salgo de casa. Y si pienso que ya está ahí otra vez, es cuando vuelve a empezar.
¿Y qué pasa cuando tiene que concentrarse en algo de verdad?
En ese caso desaparece. Cuando uno está ocupado, no piensa más en eso y probablemente sea esa la causa también.
¿Y cómo es cuando hace deporte?
Cuando hago deporte también desaparece, por lo menos casi siempre, excepto cuando vuelvo a pensar en el mareo. En ese caso vuelve a empezar.
¿Y cómo es cuando bebe cerveza o vino?
Entonces suele desaparecer, también cuando estoy en compañía de gente.
¿Hay algo que reduzca los síntomas?
No, no lo hay.
¿Hay algo que lo incremente, como grandes almacenes, muchedumbres, habitaciones pequeñas o
nada de
espacios
eso,
muy grandes?
No.
Para terminar, si tuviera que describirse a sí mismo, ¿cómo describiría su personalidad?
Sí, me concentro mucho en mí mismo y también me autodiagnostico muchas veces.
¿Cuál es diagnóstico correcto? Mareo funcional. Sí. Easy. Simple. Okay, so it's the most frequent cause of vertigo and dizziness. And there are different subtypes which are not necessarily needed to know. Just call it mareo funcional. That's a good term. And it also connects the symptoms of the patient with the pathophysiology. Because what these patients are permanently doing, they check their balance. Can you stand up, please, everybody? Don't touch the chair and don't touch the table. Now we do a kind of Romberg. Okay, both legs together, hold your arms like this. Now close your eyes. And now check your balance. Check whether you sway or not. Is anybody not swaying? You will have a problem. So you have to sway a little bit. Otherwise, your sensors don't get any information. The sensors detect not velocity, but change of velocity, acceleration. So we all sway, but normally we're not aware of that. The problem begins when you notice that you sway and you interpret this sway as mareo. And that's the beginning of your career. Now sit down, otherwise you get functional dizziness. Okay, so that's the cue. And this is what you have to tell the patient. And that's also found in this painting. I'm sure the painter did not know what he's painting, but I found that many years in the annals of the New York Academy of Sciences. So permanent checking of self, of balance, although you stand on firm grounds. Here are the diagnostic criteria. So subjective instability of posture and gait, fluctuating symptoms. If you have phobic postural dizziness, there are triggers. Then improvement with light alcohol consumption and sports, because then you don't check your balance as well as you normally do. Less symptoms in the early morning, because it takes a while until you move out your antennas. That's a very helpful diagnostic criterion. Increasing avoidance behavior. Is anybody in the audience who's not a perfectionist? Can you raise your hand? Okay, we are more or less, and we have a higher risk. At the beginning, you often have a vestibular disorder which triggers the disease. And we did this study, changes during daytime. In blue here, functional dizziness. Downbeat, they have more symptoms in the morning. Bilateral vestibulopathy, they have more symptoms at night because they get tired. So the question is very important. How do you feel in the early morning? Oh, everything is fine. But as soon as I leave the house, then it begins. That's very helpful. You see here Garfield, when I get up in the morning, everything is fine, but after breakfast. Remember Garfield for your next patient. We have to have positive criteria. I don't make the diagnosis when I don't find anything else. Then I just describe mareo of unknown cause. Good. Here's a long list. Take a photograph of this, of patients who have mareo persistente. Very frequent. There are three categories. Disordines vestibularis periféricos, disordines centrales, mainly cerebellar dizziness, and mareo funcional. That's it. If you have this pattern in your mind, you will find the patient's diagnosis. Okay, treatment is complete diagnostic, explain the mechanism, what leads to mareo funcional, desensitization by self-exposure, no vestibular exercises. They are counterproductive, except the patient has a vestibular deficit, and about 1/3 of the patient need an SSRI. So I think during the last 60 minutes, We went through on how to take patient history, how to examine the vestibular and the oculomotor system. You're familiar with the 4 categories of the diseases. You're now familiar with the most frequent peripheral, central, and functional disorders, how to diagnose and treat. Look for your next dizzy patient. You will like him, and he or she will like you. Yes, you can, and you make it. And this slide should be the basis for any questions which you have, also beyond the topics we have discussed. And I would like to thank the interpreter. We already had the pleasure today, and we also had the pleasure last year in Merida at the national conference. Muchísimas gracias.